Hope you are doing good. And in this video session, we are going to discuss about the surgical anatomy of the anal canal. We are going to discuss about the anal canal under following headings. First, we will see the introduction to anal canal. What is that? And next, we are going to see location, extent, and dimension of the anal canal. And briefly, we will visit to the embryology of the anal canal. And then we will discuss about the enorectal ring, particularly the puborectalis muscle, then anal sphincters and the intersphincteric planes, epithelium and subepithelial structures, and lastly neurovascular supply with clinical aspects. So what is anal canal? Anal canal is a area of obscurity and limited knowledge in the field of medicine and surgery. So many clinical conditions involving the anal canal are common and benign, which can be cured by simple surgeries, but they often lead to incapacitating interference with the patient's daily life because of the hindrance of the patient to visit the doctor or the location of the anal canal, so where the patient feels shyness to go and approach the doctor. So this video is making an attempt to improve our reservoir of the knowledge of the anatomy and function of the anal canal along with the basic physiology of the pelvic floor, that is pelvic diaphragm, so that it should facilitate the diagnosis and management of both common and rare conditions involving the anal canal. So anal canal, it is the terminal part of the lower intestine below the rectum. It begins at the enorectal junction, then it is directed downwards and backwards towards the anal opening, and it lies 2.5 to 3 cm in front and little below the tip of the coccyx here. So this is the direction, directed downwards and backwards, opens at the anal orifice, which is lying 4 cm below the tip of the coccyx. Then coming to the surgical anatomy of the anal canal, it begins at the enorectal junction and terminates at the anal verge. So this much is the terminal part of the elementary canal that we call it as anal canal, and it roughly measures around 2 to 4 cm in length, generally longer in the males than the females. And anal canal is completely extraperitoneal. If you talk about the peritoneal relations, we have discussed about the rectum. In the rectum, the peritoneum is only seen in the anterior and lateral surface of the upper 1/3 and anterior surface of the middle 1/3, whereas lower 1/3 of the rectum and the entire anal canal is extraperitoneal. Coming to the visceral relations of the anal canal, anteriorly the perineal body, a fibromuscular node, and you can see membranous urethra and bulb of penis in the males, whereas in the females the lower end of vagina lies anteriorly. Posteriorly in both sexes you will see anococcygeal ligament and tip of coccyx. Laterally the ischio-anal fossa, and around the anal canal you will see sphincteric muscle. The tone of these muscles keep the anal canal closed. So if you see here anteriorly the relations, what are the relations anteriorly here? You can see the perineal body and part of the male urethra and bulbospongiosis in males, whereas in the females the perineal body and lower part of the vagina. Whereas posteriorly in both sexes you will see anococcygeal body and tip of the coccyx, and surrounded by these sphincteric muscles. And on either side you will see a wedge-shaped fossa, that is ischio-anal fossa. We have discussed about this ischio-anal fossa in the previous videos. Please go and see. So ischio-anal fossa is a wedge-shaped fossa between the ischial tuberosity and the sloping fibers of the levator ani. So here is the ischio-anal fossa on the lateral sides of the anal canal. So coming to the embryology, This anal canal is a part of the gut tube which is derived from both endoderm and ectoderm. The ectoderm will invaginate from below. The part which is here, this much part is derived from the endoderm, and the lower part here it is derived from the ectoderm. So the ectodermal part is derived from the structure called as proctodium, whereas the upper part is derived from the endoderm, that is the primitive rectum and anal canal, from the cloaca. So a line between them is called as pectinate line. It divides the endodermal and ectodermal parts or sources of the development of anal canal. Coming to the interior of the anal canal, the interior is divided into three parts: the upper area above the pectinate line, intermediate area, the pectine, and the lower area below this mucocutaneous junction that we call it as white line of Hilton. So these are the three areas that you see: upper one third, middle one third, and lower one third. The upper one third is roughly around 1.5 centimeter in length or 15 millimeter. It is endodermal in origin, lined by the semi-transparent mucous membrane and having the simple columnar or stratified columnar epithelium depending upon the function, and is plum red due to the underlying blood vessels. And you will see these following features here. You will see the anal columns, these are longitudinal columns. Then you will see anal sinuses here between them, and you will see anal walls. So you can see there, you can see these anal columns or columns of Morgagni are permanent longitudinal mucosal folds, whereas in the lower part of the rectum you will see temporary longitudinal folds, whereas in the upper one third of the anal canal you are seeing the permanent longitudinal mucosal folds developed from the reduplication of the mucous membrane and contains the tributaries of the superior rectal vein. You can notice there the venous plexus is here, the internal venous plexus on the either side of the upper one third, and you can see anal valves, the lower cradle like parts of the columns, they are called as anal walls of ball. These are crescentic mucous folds. Here you can see these are the anal walls that you observe in the lower part of the rectum, upper one third of the anal canal, and connect the lower end of the anal columns. So anal valve joined together at the lower end of the anal columns. And coming to the importance of this pectinate line, or also called as dentate line, it divides the anal canal into upper and lower areas. Development wise it is different. Above the pectinate line, the part of the anal canal is derived from the endoderm, whereas below it is derived from the ectoderm. And arterial supply also differs, which you can see in this table in detail. You can see there above the pectinate line, the lymphoid drainage is to the internal ilia group of lymph nodes, whereas below it superficial linguinal lymph nodes below the Hilton's line. And epithelium, above the pectinate line you will see columnar epithelium, whereas below the pectinate line stratified squamous epithelium. And the embryological origin, above the pectinate line is endoderm, below the pectinate line is ectoderm from the proctodium. Above the pectinate line superior rectal artery, below the pectinate line middle and inferior rectal arteries, and veins correspond to the arteries. And hemorrhoids, because the internal hemorrhoids are not painful because of the nerve supply, that is by the autonomic nerves, by the inferior hypogastric plexus having sympathetic and parasympathetic supply, whereas external hemorrhoids below this pectinate line are painful because they are supplied by the somatic inferior rectal nerves. So the pectinate line is acting as a watershed line between the upper and lower parts of the anal canal, and it is not usually seen in the clinical practice, but under anesthesia when the muscles relax it descends in the anal canal and can be seen on the retraction of the perianal skin. And you can also see the anal sinuses, the gaps between the two columns, and these anal sinuses form the furrows in the anal canal that separate the anal columns. And you will see anal glands there open in the floor of the sinuses, and if they get infected they lead to fistula, a epithelialized tract between the anal canal and external environment. You can notice here, you can see this is the fistula. And coming to the intermediate area between the pectinate line and white line of Hilton, roughly around 1.5 centimeter in length. It is also ectodermal in origin, and all the features what we have seen in the upper one third, they are absent there. It is bluish pink in appearance, lined by stratified squamous epithelium, and it does not have any kind of sweat or sebaceous gland. And you can see there the intermediate is also called as the area of pectine. The color contrast between the blue pink mucosa and black skin below, and it lies at the lower end of the internal anal sphincter. The pectine is a smooth area of hairless stratified epithelium. You can say it is stratified squamous non-keratinized epithelium there. And coming to the anal verge, the lower one third, roughly around 0.8 centimeter in length, derived from the ectoderm. It is lined by true skin, that is the thin skin, stratified squamous keratinized epithelium, and it shows corrugations because of the smooth muscle there, corrugator cutineae, and it also has coarse hair around the anal opening. So this anal canal is maintained by the pelvic floor muscles. So let us see what do you mean by true pelvis and pelvic floor. The true pelvis is a sink shaped or a basin shaped structure from the sacrum, pubis, ilium and ischium and ligaments around that. It extends between the pelvic inlet and pelvic outlet. The area below pelvic outlet is called as perineum, and area between the inlet and outlet is called as the true pelvis. The true pelvis, you can see there, the floor of the pelvic cavity is formed by the pelvic diaphragm. And when you see the different muscles here, the muscles and fascia of the pelvis, the fascias are pelvic fascia, perineal fascia, and laterally you will see obturator fascia, whereas the muscles are formed by this lateral wall is formed by the piriformis and obturator internus. These two muscles form the lateral wall, whereas levator ana along with the coccygeus, it forms the pelvic diaphragm. So when you see here in this sagittal section of the pelvis, you are seeing the muscles of the lateral wall, that is obturator internus and piriformis muscle. These both exit the pelvis via the sciatic foramina. Piriformis pass through greater sciatic foramina, and obturator internus tendon pass through lesser sciatic foramina. They both attach to the femur, the greater trochanter of femur acting as lateral rotators of the hip. But the obturator internus is covered by a fascia here, that we call it as obturator fascia. We have discussed about this in the lateral of the ischial fossa. And here in the center it has a thickening of the fascia that we call it as a tendinous arch. This tendinous arch is important in understanding the origin of the muscles forming the levator ana and pelvic diaphragm. So that's why these lateral wall muscles are important. And you can see here the base of the pelvis seen in lithotomy position. You can see all these muscles covering the urogenital triangle and anal triangle. And next, coming to the enorectal ring, it marks junction between the rectum and anal canal, that you can see here, the enorectal ring. It surrounds the junction between the rectum and anal canal like a sling. It is formed by the puborectalis muscle. It is a part of deep external sphincter. It also has some conjoint longitudinal muscle, and it is the highest part of the internal sphincter. So, what is the surgical importance of this enorectal ring? See, this enorectal ring maintains the what you can say continence of the anal canal. Damage to this ring results in incontinence, where patient cannot hold the act of defecation. So it must be protected during the surgeries in case of fistula and fissures or piles. You can see there the enorectal ring can be felt digitally in the per-rectal examination as a thickened ridge, especially in the posterior and lateral aspects. And let us see here the muscles forming the pelvic floor, that is the pelvic diaphragm. What you are seeing here from the anterior side, when you peek into the pelvic cavity, you can see this is the entire sheet. This is pelvic diaphragm formed by the levator ana and ischio-coccygeus muscle. Levator ana is not a single muscle. It has different small muscles like pubococcygeus and iliococcygeus. You can see here. Yes, this is when you see in the posterior aspect. Again, this is in the lithotomy position. When you see the perineum, you are observing the pelvic diaphragm, a bowl-like floor, and in the lateral wall, you are seeing the two muscles, that is obturator internus anteriorly, and you can see the obturator internus is coming from the pelvic surface of the pubis, ischium and ilium bones, and also from the obturator membrane. It forms a tendon which exits the pelvic cavity passing through the lesser sciatic foramina, and more posteriorly you are seeing piriformis. It takes the alphabet E-shaped origin there from the ventral surface of the sacrum, and it exits the pelvic cavity by passing through greater sciatic foramen, and both obturator internus and piriformis attach to the greater trochanter of the femur and act as the lateral rotators of the hip joint. And when you see the levator ana, this is the pubococcygeus part coming from the posterior surface of the pubis and tendinous arch, that is iliococcygeus, taking origin from the tendinous arch, that is coccygeus part of pelvic diaphragm. The pubococcygeus and iliococcygeus together form pelvic, this levator ana plus iliococcygeus form pelvic diaphragm. And when you observe the urogenital triangle of the male perineum, you are seeing these perineal muscles, bulbospongosus, these are ischiocavernosus. Here you are seeing the superficial transverse perineum, and the here deep transverse perineum, that is superficial. And here you can see these muscles are attached to the perineal body here. The perineal body is a fibromuscular node. So you can see there, and you'll also see the part of the external anal sphincters attached to the perineal body. And here you can see that is the pubococcygeus part, and this is the puboanalis or rectalis, puborectalis. It forms a sling around the enorectal junction, forming the enorectal ring. So this muscle forms the sling here, puborectalis, forming the enorectal ring, maintaining the continence of the anal canal. And you can see here, this is the external anal sphincter muscle, the superficial part. You can see here, you are seeing the posterior part of the perineum, that is the anal triangle. You can see these three muscles, they form external anal sphincter. The subcutaneous part, the lowermost is subcutaneous, middle one is superficial, the upper one is the deep part of the external anal sphincter. So these three muscles, they form external anal sphincter and maintain the voluntary control or continence of the defecation process. And more behind, if you go, you will see, and that is the part of the Enorectal Ring, that is pubococcygeus part, and you can see that is enococcygeal ligament attached to the tip of the coccyx. So these are the muscles you see in the anal triangle of the perineum, which are common to both male and female. That is subcutaneous part. Then just above it you will see that is the ileococcygeus part. You can see how these muscles maintain the bowl-like shape of the pelvic diaphragm, as you can notice here. That is the ileococcygeus part of the levator ani, and this pubococcygeus, it again has different parts surrounding the different openings. Around vagina it is called as pubovaginalis, around the bladder it is called as pubovesicalis, around rectum it is called as puborectalis, and around the anal canal puboanalis. Around the prostate it forms the puboprostatic muscle, some fibers, that is pubococcygeus, attached to the tip of the coccyx there. So it is not coming entirely from the pubis, partly from the pubis and anterior half of the tendinous arch, the white tendinous arch, what you are seeing here, thickening of the obturator fascia. So this lateral wall of the pelvis has important contribution to the origin of the levator ani and formation of pelvic diaphragm. You can notice there, this much part is ileococcygeus, it is thinner. This much is pubococcygeus, and you can notice the direction of the muscle fibers of the levator ani directed downwards, backwards and medially. These fibers maintain the position of all the urogenital organs and rectum and anal canal. Posteriorly you are seeing this much is ischio-coccygeus or simply coccygeus. Together this entire sheet is called as the pelvic diaphragm. Both sides they form pelvic diaphragm and guard this urogenital hiatus. And here you will see urogenital diaphragm. So let us see here. So you are seeing the sagittal section of the pelvis with the piriformis there, coming from sacrum and leaving the pelvic cavity via greater sciatic foramina. And here in the lateral wall you are seeing the obturator internus muscle here, taking origin from the pubis, ischium and ileum, and obturator membrane which covers the obturator foramina. It covers there and exits the pelvis by forming a tendon, the tendon of obturator internus, along with these pudendal nerve, internal pudendal vessels. You can see there they insert into the greater trochanter of the femur and act as lateral rotators of the hip joint. Why we are studying all these muscles in detail here? To understand the pelvic diaphragm and its role in the formation of the sphincters. And this obturator internus is covered by the obturator fascia, and that thickening white tendinous arch, it is giving origin to the pubococcygeus and ileococcygeus parts of the levator ani muscle. So that's why this tendinous arch is important. You can see there below this tendinous arch the levator ani slopes. Here you are seeing the coccygeus muscle, the posterior part of the pelvic diaphragm. This is levator ani. And here you can notice how it is directed downwards, backwards and medially. That is the pubococcygeus coming from the pubis till the ischial spine. That is the extent of levator, and see how this pubococcygeus and ileococcygeus is taking origin from the white tendinous arch. So you can see there direction of the fibers, and they meet in the midline with the opposite fibers to form a midline raphe. You can notice there. And between this levator and ischial tuberosity, that is ischial tuberosity, sacrotuberous ligament, and the sloping fibers of the levator, there will be ischiorectal fossa. And coming to the parts of levator, that is ileococcygeus part, taking origin from the posterior part of the tendinous arch. It is thin compared to the pubococcygeus. Then here is pubococcygeus taking origin from the pelvic surface of the posterior surface of pubis bone and directed downwards, backwards and medially. And more posteriorly you are seeing the coccygeus. If you add both the sides, you can see the bowl shaped pelvic diaphragm, that is tendinous arch on the right side, that is ischial spine, and you can see there this much is coccygeus muscle here. So these are levator muscles, and that is urogenital hiatus. The pelvic diaphragm surrounds them, maintains them in position, in standing position whenever they are in action, and the entire pelvic diaphragm is covered by the pelvic fascia. You are seeing the superior fascia there, that is the enococcygeal ligament. We have seen that in the animation, and you can see that is the puborectalis muscle forming the enorectal ring. The lower fibers are called as puboanalis, and as you can see there, these are some fibers of pubourethralis, pubovesicalis, and when you see them with the structure surrounding them, that is rectum, lower part of the rectum and anal canal, the urethra, this is how the pelvic floor is visible when you view it from above, covered by pelvic fascia. And when you view it from below, you can see the muscles there. You are seeing it from the below, that entire portion. You can see the pelvic diaphragm, that is the pubococcygeus part. You can see puborectalis muscle there forming a sling, that is urogenital hiatus, that is enococcygeal ligament, and if you add the anal canal, you will see the external anal sphincter having the subcutaneous part, superficial part and deep part. The subcutaneous is just below the skin. The superficial part is having attachment to the tip of the coccyx, whereas deep part is with the puborectalis. So you can see there anal canal opening. So puborectalis is a U-shaped medial most part of the levator. It pulls the enorectal junction anteriorly. Here you can see it is pulling the enorectal junction anteriorly, maintaining this enorectal angle, and at rest it creates a sling and forms an acute angle that distributes the intra-abdominal forces to the pelvic floor. With defecation, it relaxes and angle straightens, allowing the downward force for the act of defecation, and non-relaxation of puborectalis results in constipation. And coming to the anal sphincters, there are two sphincters, internal and external. The external sphincter is voluntary, composed by the skeletal muscles around the entire length of anal canal. Consists of three parts, which you have seen in the animation and dissection specimen. The subcutaneous, superficial, and deep parts supplied by the voluntary nerves, that is the inferior rectal branch of the pudendal nerve and perineal branch of the S4. And you can see there the deep part, superficial part, and the subcutaneous parts there. And here is the entire internal sphincter. And you can notice there the subcutaneous part, it surrounds the anal canal. Superficial part is coming from the tip of the coccyx to the perineal body here, whereas the deep part it also surrounds but is in close relation with the puborectalis. So you can see again the parts of the external sphincter. So this sphincter tone can be assessed by the distal rectal examination when patient asked to squeeze the examining finger, and the intersphincteric plane between the internal and external sphincter can be a site of the abscess, and it can be a plane for surgeries to provide access to the operations on the sphincteric muscle in case of fissures. And the longitudinal muscle of the rectum and anal canal is a continuation of the outer coat of the wall of the anal canal, and at the enorectal junction the outer longitudinal layer becomes fibroelastic. It forms a conjoint fibroelastic sheath along with the puborectalis and passing between the two sphincters there. You can notice here this longitudinal muscle is forming a sheath here, that is conjoint fibroelastic sheath. So it supports the enorectal junction and anchors them. And coming to the internal anal sphincter, it is involuntary sphincter. It can be felt as a thickening of the circular muscle in the lower part of the anal canal. The lower end of it corresponds to the Hilton's line, that is mucocutaneous junction, and externally separated from the external sphincter muscle by a conjoint sheath. Being involuntary, it is supported by superior and superior epigastric plexus and pelvic splanchnic nerves. And when you expose in the dissection, it appears as a pearly white circumferentially surrounding the anal canal. Here you can notice the whitish fibers of the internal sphincter. So what is the function of these anal sphincters? They allow defecation and maintain the continence. The act of defecation has four components, that is mass movement, the rectoanal inhibitory reflex, voluntary relaxation of the external sphincter, and increased intra-abdominal pressure by the anterabdominal wall muscles and diaphragm. Coming to the blood supply of the anal canal, the hindgut, it is supplied by the inferior mesenteric artery, that is the endodermal part. It gives a branch called a superior rectal artery, whereas distal anus part is derived from the ectoderm, supplied by the internal pudendal artery. That's why above the pectinate line or dentate line, the arterial supply is by the superior rectal artery. Below it is by the middle and inferior. Inferior rectal artery is a branch of internal pudendal. You can see here the distribution of the arteries supplying both rectum and anal canal. You can see middle rectal artery there, inferior rectal artery, and median sacral artery. We have discussed about these arteries in detail in the session of the anatomy of the rectum. Please go and refer that. And coming to the venous drainage, above dentate line is by the inferior mesenteric vein, which is a part of the portal system because it joins the splenic vein. Splenic vein is the formative tributary of the portal vein, whereas below dentate line it is by the internal iliac veins. So anal canal is a site of portocaval anastomosis. So the veins get engorged in case of portal hypertension. So you can see there we have discussed in detail about these plexus in the previous video. So coming to the innervation, above the pectinate line by the sympathetic and parasympathetic, by superior hypogastric and pelvic splanchnic nerves, below it by the inferior rectal branch of the pudendal nerve. Lymphatic drainage, the mucocutaneous junction drains into the superficial inguinal lymph nodes. Above it they drain into these internal iliac group of lymph nodes. And the continence of the rectum and anal canal is maintained by the normal capacitance, sensation, puborectalis function, external sphincter function, and also the internal sphincter function for the resting pressure. So what is incontinence? It is the inability to prevent the elimination of the rectal contents or inability to prevent defecation or act of defecation. So it may be due to mechanical trauma during the delivery of the baby in females, or fistulotomy or fissurectomies, or in case of hemorrhectomies, and some in case of the neurological deficits, and also in case of some GI infection like diarrhea. So you can see the fistula there. Fistula is a tube-like connection lined by the epithelium between the interior of the anal canal and the external environment. And some congenital anomalies like imperforativeness happen when there is no communication between the ectodermal part or endodermal part, or when anal membrane fails to rupture. And you can see these numerous congenital anomalies there. The rectovesical fistula here, because these both are derived from the cloaca, the persistence of the cloacal duct. And rectovaginal fistula, it is due to persistence of the cloacal duct in females. So these are the different congenital anomalies. Coming to the anal fissure, it is a split in the epithelium. It occurs due to poor blood flow or during constipation, and it is usually treated by the lateral internal sphincterotomy. And hemorrhoids, also called as piles, they are engorged vascular cushions found within the submucous of the anal canal. So they are usually found in these three positions: 11 o'clock, 7 o'clock, and 3 o'clock positions. You can see there the external piles on the left side, and in the middle you can see the internal pile, and some will be mixed. So internal piles are not painful because they are supplied by the autonomic nerves, whereas external piles are painful because they are supplied by the somatic nerves. So if you summarize the entire anatomy of the anal canal, so internal sphincter is composed of circular smooth muscles which are involuntary. The external sphincter is composed of the skeletal muscles which are supplied by pudendal nerve. The extension of the longitudinal muscle of the wall of the anal canal provides support to the sphincteric complex, and the intersphincteric plane between the sphincters is important for surgical access. The deep part or superior part of the external sphincter fused with the puborectalis muscle. The lower part of the anal canal is lined by the stratified squamous epithelium, which is sensitive, and blood supply to the anal canal is by the same vessel supplying the rectum. So the pectinate line act as a watershed line. So this much is about the anatomy of the anal canal, or you can say surgical anatomy of the anal canal. So This enorectal area is a complex region with multiple anatomical and physiological interaction, maintaining the continence and act of defecation. So a rectal examination is essential for any patient. So they say in surgery, if you don't put your finger in, you might have to put your foot in it. So per rectal examination is must in case of any symptoms or signs involving the rectum and anal canal. So these are the references for your consideration. Hope it is useful. Thank you. Thank you very much.